lecture devoted to the disease of the retina. So we'll start in 1 minute. Okay. So the retina is the innermost layer of the eye and is derived from neuroectoderm. Wait a bit, I need to switch off your microphones, I mean. It is composed of two layers. The outer, the so-called retinal pigment epithelium, and the inner, neural retina with a potential space between the two layers. Retina extends from the optic nerve to the so-called ora serrata. Grossly, it may be divided into four low regions. Optic nerve disc, it looks like pale pink circular area of about 1.5 millimeter diameter, where nerve fibers pass through the lamina cribrosa to run into the optic nerve. Second very important part of the retina is yellow spot or macular lutea. It is comparatively dark area situated temporally to the optic disc and the peripheral retina. Macula contains the thin sloping fovea and is made almost entirely of cones, photoreceptors, which are responsible for the central vision, for the color vision, and for the vision in dim light. It is the site of detailed fine central vision. Visual acuity drops off rapidly in the perimacular areas. Ora serrata. It is the serrated peripheral margin where the retina ends. Here, the retina is firmly attached both to the vitreous and the choroid, part of the uveal tract. There are a lot of diseases of retina, but there exists a group of complaints, common complaints of the patient, and they are decreasing of the central and peripheral vision, degree of the defective vision, defects in the visual field, disorders of the dark adaptation, depends on the localization and spreading of the pathological process. The retina, and it's very important, the retina has no sensitive innervation, therefore there is no pain in case of retinal diseases. Such complaints as pain in the eye is absent in case of retinal disorders. There exist a lot of tests for retinal functions, and tests of the retinal functions include visual acuity examination, visual field examination, testing of color vision, and dark adaptation. Fluorescein angiography and electrophysiological investigations are widely used. Different methods of ophthalmoscopy are used for examination of the fundus. Direct and indirect, which we usually train during our face-to-face classes, practical classes, biomicroophthalmoscopy, ophthalmochromoscopy, when we use different colors of the ophthalmoscope source of light to examine different structures of the retina in different colors. by micro-ophthalmoscopy, we use a binocular microscope, slit lamp, additionally to the special lenses for examination of different, especially peripheral parts of the retina, which we can't see without the special equipment. Among the diseases of retina, the main forms are retinal manifestations of systemic disorders. For example, endocrine pathology like diabetes mellitus or thyroid gland pathology, cardiovascular diseases from arterial hypertension to disease of the blood, inflammatory disorders, dystrophies and degenerations of the retina and their complications, and of course, tumors of the retina. Let's discuss several of these groups and the examples of different disorders in each group. Let's start with the retinal changes in systemic disorders and retinal changes in arterial hypertension. As you know, a lot of people suffer from hypertension with its effects on the arteries of the heart, brain, kidney, and the retina. Essential hypertension is associated with thickening of the arterial walls caused by hypertrophy of muscle fibers in the media and by an increase of fibrous tissue in the intima of the blood vessel walls. There exist a lot of classification of hypertensive retinal changes. In our country, we use Krasnov classification, which includes 4 stages: hypertensive angiopathy, hypertensive angiosclerosis, hypertensive retinopathy, and hypertensive neuroretinopathy. As you can see, these are 4 grades. We can say that these are 4 stages of the same disorder. Start with the angiopathy, means problem only with the blood vessels, and come to the retina and neuroretinopathy, associated changes in the retina and in the optic disc. Several words about each of these stages. In stage of hypertensive angiopathy, this stage is characterized by the mild narrowing of arterioles and a broadening of retinal veins. Correlation arteries to veins is 1 to 4 instead of 2 to 3, normal correlation. And irregular diameter and increased windings of the retinal vessels are also present in this stage. The next stage is hypertensive angiosclerosis, which include changes of the first stage and additionally also symptoms of copper wire and silver wire. It is an arterial reflex because of the hyalinosis in the first case and obliteration of the blood vessels in the second, and in the silver wire symptom. We can check and we can determine these changes during the ophthalmoscopy. And if you see that the blood vessels, arterial blood vessels of the retina looks like the copper wire, it means that there exist changes of the walls of the blood vessels associated with the second stage, hypertensive angiosclerosis. If you see silver wire, it means there exists obliteration and decreased or absence of the blood flow in these blood vessels. Then there exists a symptom of Salus-Gunn. It's a symptoms of arteriovenous crossing. These symptoms are typical. The first grade of this symptom is characterized by narrowing of the veins or on either sides of the crossing. Salus 2 is characterized by deflection of the vein, and Salus 3 when we can see a break in the vein crossing by the artery. The next stage of hypertensive changes is the stage of hypertensive retinopathy. which consist of changes of previous stages, first and second stages, and plus different types of hemorrhages. And soft exudates looks like during the ophthalmoscopy looks like cotton wool spots in different parts of the retina. And additionally, hard exudates also may be retinal edema, and the deposition of hard exudates around the fovea in the central part of the yellow spot may lead to a macular star configuration. Let's have a look at the patients with hypertensive retinopathy. So, optic nerve disc looks normal, pale pink with the sharp borders. Blood vessels, we can see wide veins, dark veins, and very narrow arteries. If we will try to measure the diameter, the correlation will be 1, the correlation of arteries to veins will be 1 to 4 in this case, I think. Then we can see crossing, Salus Gans symptom. Here you see Salus 2, when we can see narrowing of the vein on both sides of its crossing, where we can see the cross of the arteries and veins. One more, Salus 3, because we can see like a break in the vein in this area where the vein is crossed by the artery. And these are symptoms of the first stage of arterial hypertension and arterial hypertensive angiopathy and hypertensive angiosclerosis. And additionally, in this stage of retinopathy, we can see changes not only of the blood vessels, but additionally changes of the retina in form of different types of hemorrhages. You can see them like spots, dots in different areas of the retina, somewhere on the periphery, here, 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 and even here in the yellow spot area. So these are intraretinal hemorrhages. Then different types of exudates, soft and hard. So what's the difference between them? In case of soft exudates, they have no sharp borders. They usually looks yellowish, whitish, like cotton wool spots. So you see them in this photo here, 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 in these peripheral parts of the retina. So these are soft exudates. And there exists a group of hard exudates in form of small yellowish spots, dots of, usually they are smaller than the soft exudates and they have sharp borders. In this picture, you can see them in form of very small dots here in the peramacular region. So this is the stage of hypertensive retinopathy, changes of the blood vessels, changes of the retina, but no changes of the optic nerve. And the fourth stage of hypertensive changes is the stage of hypertensive neuroretinopathy. Hypertensive neuroretinopathy may present with symptoms of previous stage of hypertensive retinopathy and changes of the optic nerve disc in form of disc swelling, flame-shaped hemorrhages at the disc edge. At the final stage may be atrophy of the optic nerve disc. Swelling of the optic nerve disc is the hallmark of the malignant phase of hypertension. So if you are, for example, a general practitioner or therapist or cardiologist, and you ask the ophthalmologist to check the fundus of the eye and to determine the stage and the severity of the damage of the different organs, because hypertension, arterial hypertension, is a multi-organic pathology. And if in the ophthalmologist's conclusion you'll find words about the swelling of the optic nerve disc. It's a rather bad symptom. It's a prognosis for the progress of the hypertension, and even sometimes for the patient's life is doubtful in this case, unfortunately. So in this case, we talk not only about the eye or visual functions, but about the total general symptoms and about the organism in a whole. Such patients have decreased visual acuity. Patients with this stage of hypertensive changes, defects of the visual field, and of course, problem with the other visual functions. Here you see such patients with a severe disc edema, and you see no sharp borders of the disc. One more patients with neuroretinopathy, also edema of the disc, a lot of changes on the periphery and in the central part of the retina in form of large cotton wool spots, and deposition of hard exudates in the yellow spot in form of star. You see such lines of yellowish hard exudates. Treatment of hypertensive changes depends on the stage, of course, but as you understand, all these changes are secondary, and no need to treat them. There will be no efficacy. I mean, if you will treat them without the treatment of the systemic disorder, without compensation and stabilization of the arterial hypertension, only in this case we can wait for the result of our local treatment. In all other cases, unfortunately, symptomatic treatment will be not effective. So systemic hypertensive drugs, but it's not the response of the ophthalmologist, of course. It's duty of the cardiologist, therapeutic, general practitioner, and so on and so forth. And symptomatic treatment, sometimes you can try to use angioprotectors, vasodilators, retina protectors, drugs which can increase the exchange processes in the retina and help to decrease the edema or to prevent the secondary hemorrhages, and so on and so forth. Sometimes you can see spontaneous resorption of the hemorrhages if your patient has non-progressive type of hypertension with a good stabilization, good arterial blood pressure. In this case, we can see in several weeks or even months spontaneous resorption of this edemas and of these hemorrhages with the recovery and partial or total of the visual functions. The next very important disorder, systemic disorder, which associated with sometimes very severe changes of the fundus of the eye, is diabetes mellitus, and the name of this pathology of the eye is diabetic retinopathy. Diabetic retinopathy refers to retinal changes seen in patients with diabetes mellitus. Diabetes is characterized by sustained hyperglycemia secondary to lack of endogenous insulin in some cases. The prevalence of diabetic retinopathy is higher in insulin-dependent diabetes, about 40%, than in non-insulin dependent diabetes. And diabetic retinopathy is the most common cause of legal blindness in individuals between the age of 20 to 65 years. So among this group of rather young people, this is one of the main causes of blindness, irreversible, unfortunately, irreversible blindness in all the world. Diabetic retinopathy is a microangiopathy affecting the retinal precapillary arterioles, capillaries, and venules. However, large vessels may also be involved. Retinopathy has features of both microvascular occlusion, and macrovascular leakage. Clinically, there exist three main types of diabetic retinopathy. Not types, but maybe stages. They are background or non-proliferative diabetic retinopathy, pre-proliferative diabetic retinopathy, and the final stage of the process, proliferative retinopathy. Non-proliferative or background retinopathy. Ophthalmoscopic features of this type of diabetic retinopathy include venous dilation and fullness. Here you see dilated veins, capillary microaneurysms, retinal hemorrhages. Like here you see a lot of hemorrhages in the central part of the retina. Deep dots and blots and superficial flame-shaped. Then hard exudates. You can see here them somewhere in the periphery, and retinal edema. With the help of special methods like optic coherence tomography, we can determine and even measure the retinal edema in nanometers, in micrometers, and compare the results of this investigation before and after treatment. And with the help of these methods, modern technologies, we can determine the efficacy of our treatment. The next stage of the diabetic retinopathy is pre-proliferative retinopathy. In this stage, changes are superadded to the changes of non-proliferative diabetes of the eye. All the clinical lesions are caused by retinal ischemia. Pre-proliferative diabetic retinopathy is categorized by the presence of intraretinal microvascular anomalies, multiple cotton wool spots, you see them, blood retinal hemorrhages, also you can see them around the blood vessels, along the blood vessels, and vascular changes, venous dilation and feeding. Severe macular edema is present in these patients. Approximately 10 to 50% of patients with pre-proliferative retinopathy develop proliferative retinopathy within a year. So without a treatment, time from the pre-proliferative to the most severe proliferative stage is less than 1 year. And proliferative retinopathy. It is affects about 5–10% of the diabetic population, but these 5 to 10% have a severe loss of visual functions with the development of partial or total blindness. So neovascularization is a hallmark of proliferative diabetic retinopathy. New vessels may proliferate on the optic disc and along the course of the major temporal vessels elsewhere in the fundus. These new vessels may proliferate in the plane of retina or spread into the vitreous body. Later on, condensation of connective tissue around the vessels results in formation of fibrovascular epiretinal membrane, and vitreous detachment and vitreous hemorrhages may occur in this stage. Here you see an example of this patient with a huge pre-retinal hemorrhage due to the diabetic changes. In spite of the previous very serious treatment, if we carefully look at the peripheral retina, you'll see some round yellowish or pale yellowish dystrophic focuses. Some of them are pigmented. These are laser coagulates, result of their previous laser treatment, one of the most effective ways of treatment in this stage. But unfortunately, even such a very serious and very effective methods was not so effective in this particular patient. And we can see a huge hemorrhage which cover partially the optic nerve disc and cover totally the optic of the area of the yellow spot with the severe loss of visual functions. If you try to check visual acuity of this patient, he will have very poor vision with his peripheral retina and no central vision. It will be for a sort of scotoma defect in the central part of the visual field. So treatment of this person is difficult, and sometimes only surgery can help to remove this blood from inside the eyeball. So it's very, very difficult situation with the risk of development of the connective tissue, with the risk of development of such complication as tractional retinal detachment, severe atrophy in the central area of the retina, with partial or total blindness, irreversible blindness, even after the resorption or removing of this blood. Investigations, specific investigations include urine examination and blood sugar estimation, as usual for the diabetes mellitus. Sometimes we can see eye changes, like the first manifestation, the first symptom of manifestation of diabetes retinopathy, of the diabetic changes, I mean general diabetic symptoms. So in all the cases, it's necessary to check the biochemical investigations, urine examination, to determine the activity of the diabetes, its stage, and so on. Fundus examination includes fluorescein angiography. It should be carried out to elucidate areas of neovascularization, leakage, and capillary non-perfusion. And additionally, we can use optic coherence tomography, of course, angio OCT, to determine the same problems, but these methods are non-invasive and more popular now in all the modern clinics in all the world. Treatment of diabetes depends on the stage and type of changes. Of course, treatment of the like in case of hypertension, the treatment is more effective and is effective in persons with the diabetes under control. I mean, with the stabilized, with the good compensation of all the parameters of diabetes. Only with the decreased amplitude of fluctuation of the all these parameters, including blood sugar, including arterial blood pressure, and so on and so forth. Anti-diabetic agents for good metabolic control of hypertension. You know that arterial hypertension is very often associated with the diabetes mellitus. And local treatment, we can use angio and retina protectors, vitamins, enzymes, but the efficacy is under discussion. You know that we now live in the era of evidence-based medicine. So from evidence-based positions, all these drugs, the efficacy of these drugs are doubtful, and we need additional research examinations, additional studies to determine the real efficacy of these groups of drugs. But in several countries, you can find in guidelines such drugs as angio and retina protectors, even anabolic steroids, vitamins, and so on and so forth, for the local treatment of diabetic changes. But of course, the most effective types of treatment in this case are surgical treatment and additionally intravitreal injections. Let's start with the laser treatment. Laser treatment or photocoagulation, it's a way of prevention of the possible complications of diabetic retinopathy. If you will use it, I mean laser surgery, laser treatment in stage of pre-proliferative retinopathy, there exists a chance to stop the progress and to prevent its development of the proliferative stage of diabetic retinopathy. The principles of coagulation is to make burns of the peripheral retina to decrease the areas of ischemia, because even ischemia is one of the key pathogenetic mechanism of neovascularization, development of the pathological new blood vessels. So if you decrease the risk of ischemia, you will decrease the risk of neovascularization. So the principle of surgical treatment, laser treatment, is to make as much as possible laser coagulates on the periphery in the central part of the retina to keep the central part, the yellow spot, healthy without neovascularization, without edema, and it's very important and very effective method of prevention of severe diabetic changes if you will manage to use it in time. Surgical treatment is required in advanced stages of proliferative retinopathy. We use the so-called vitrectomy, removing of the vitreous body. And vitrectomy is indicated for dense, persistent vitreous hemorrhage, which can't be resorbed by medical treatment. Tractional retinal detachment, when presence of the connective tissue membranes, pathological membranes, in front of the retina may cause the detachment of the retina from its points of fixation. And presence of epiretinal membranes, membranes on the surface of the retina, is also indication for the vitreoretinal surgery with the help of special microforceps. Through the very small incision, less than 0.5 millimeter, we put the instruments inside the eyeball and remove the vitreous, remove the proliferative membranes, then coagulate with the help of microlaser the peripheral parts of the retina. And sometimes we use special tamponade instead of the removed vitreous. We put inside the eyeball silicone oil, sterile silicone oil, or special ophthalmic gas. In case of gas, it will be spontaneous resorption of this gas in several days or maximum 2 weeks. And in case of silicone, if you manage to stabilize and to control the diabetes of the eye, you can remove it in several months without any complications. And one more very effective method, especially for prevention of development of the growth of the new blood vessels, is the so-called injections, intravitreal injections of anti-VEGF drugs. VEGF, it means vascular endothelial growth factor. So anti-VEGF, it means drugs which cause the stop the relief and production of this vascular endothelial growth factor. This endothelial growth factor causes the development, the appearance of the new pathological blood vessels. So at the level of pathogenesis, we can stop this process. We inject 0.1 milliliters of such drugs inside the vitreous, in the vitreal cavity, and we have a very good result after several days. We can see resorption of blood. We can see a resorption of edema in the macular area. We can see occlusion, obstruction of the pathological blood vessels. And now it's maybe the most effective type of treatment, medical treatment. And it will usually help us to keep the visual functions, the retina of our patients as much as possible for a long period of time. If sometimes we can combine different types of treatment, for example, combine laser surgery with vitrectomy, combined injections of the anti-VEGF drugs inside the eyeball with the laser surgery, combine it with the vitrectomy. So there may be different variants, especially if the process, the general process, is non-stabilized. In this case, it's necessary to use different variants to save the visual functions as long as possible. So let's have a small break, and then we'll continue with the other types of retinal detachment. We'll meet again in 10 minutes.